if you have a family member in a skilled nursing home or whatever, it is your job to advocate to the doctors, advocate to the social workers. Be the voice that your loved one can't have, because the generation we're working with, they're so afraid to ask for help. That's when you jump in, or that's when I jump in, like, no, you do definitely need this help. If you need to speak to the doctor, I'm going to make sure the doctor comes in right then and there.
Welcome to In Good Company, Elder Care in Your Backyard, the podcast that brings local perspective on aging, caregiving, and healthcare right to your ears. I'm John Ray.
And I'm Spencer Ernst. Every week we talk with the people on the front lines, all making elder care accessible to you.
Well, hey, Spencer.
How are you doing?
I'm doing good. I'm
All
doing
right.
good. What's the latest news?
Well, get this. We'll jump right into our backyard briefing, won't we? There's ongoing stories about big healthcare insurance companies buying up providers. A big court case happening in Maryland right now. And so I wonder how that's going to affect local families and what that means for just providers in general.
Yeah, this is kind of a complicated issue because, this has been going on for the last 20 years, really. Insurance companies have really started to, as they become, more able to do this, they've been in positions to acquire different healthcare companies and so providers. And one of the things that has been a bit of a concern as insurance companies move into this realm is there's always been traditionally a separation of insurance and provider. So, I'm a physical therapist. I spent years as a physical therapist, and I just wanted to take care of patients. My boss didn't tell me how many visits to do or, how long to see them or whatever. If they needed more treatment, I just provided what they needed. There wasn't anything outside of what I was doing that would change how I was providing care. Insurance companies, their job is to take premiums and to pool money and to provide payment for services provided by the healthcare provider. And they want to try to mitigate costs as much as they can. They pool this money and whatever is left over from after they provide the care is profit for that insurance company. On the other side, the provider, they're just trying to provide a service, and they provide that service and they get payment from the insurance company. So you have these two sides where and on both sides there are issues. On one side, you could have an insurance company that's trying to retain too much of that and deny care or not provide care when it is required. And on the other side, you could have a provider that is trying to over-provide. And so they're increasing costs because they're providing care to people who don't actually need the care. Now, I'm not saying that this happens a lot on either side, but there's where the argument lies, in that there are issues on both sides. The problem that you could potentially run into is that when the insurance company acquires that healthcare provider, what is the goal of that? Is it to reduce cost? If that's the case, then they have more control of reducing that cost directly, and by saying, hey, provider, you need to not provide this much care. Not saying that's happening, but I'm just saying because of this acquisition, that becomes more prevalent to an issue that needs to be looked at. And the problem is that there's really no regulation or no auditing body in there that is really going to monitor this part of it. This is a relatively new thing in that these large-scale insurance companies are now acquiring all these healthcare providers. We don't know what the outcome is going to be. We don't know how exactly that's going to affect, the care provided. I do know that insurances can change how healthcare is provided. You ask any physician, he'll tell you that insurance companies affect healthcare and how people's access to it, denials, administrative burden, that sort of thing. So that's why this is such an important trend, because if people don't understand who owns that provider, and that can be very tricky to find out, by the way, but who owns that provider can change how that provider acts and because the person ultimately who's signing the paycheck is the insurance company who has this pool of money. And again, their profits are directly affected by how much care is provided. So it could potentially be a conflict of interest.
Wow. So it's kind of a severe bias almost, potentially, that could impact the patient and their coverage.
Yeah, we don't know yet exactly how that's all going to play out. We haven't really seen that because some of the bigger providers, it's relatively new. And to be honest, like they probably aren't changing a lot of things. But as things progress down the road, I think it's something that we should all have our eyes on so that we know that if an insurance company gets new leadership and they make changes at the highest echelons of that insurance company, that they're not making changes to say, oh, we have this provider can help us reduce cost. We'll make sure they're the only ones in network, and we'll make sure that they're going to provide care only to what we think they should provide care. And these are insurance people, not medical people. And so we want to try to keep a division there as much as we can. Let the clinicians be clinicians and let the insurance people, do what the insurance does. And it's important. Both sides are critical, but the idea that they should be separated hasn't really come to the forefront of society here in America, is that maybe they should stay separate for good reason, because cutting costs or controlling costs they need to be very careful with that, because they could wind up changing a trend, and oftentimes we don't see the outcomes for years. We don't look at the big data part of it. We don't see it right away. It's just slowly we start to see less visits here and, less care there, more denials here. And then all of a sudden those outcomes start to trend down. Then we're not improving our healthcare, that's for sure. And so we want to make sure that we're always trending in the right direction and making sure that those clinicians can be clinicians and provide that service, and insurance companies can continue to do the things they do to mitigate cost, and making sure that those providers aren't providing care to people who don't need it.
Wow. Well, in conclusion and briefly, so let's just say the federal government, the federal courts rather, allow these mergers to take place, and you have multiple providers and multiple insurance companies combining forces. What can families do here to help fight that or help fight for their own rights?
Yeah, advocacy is really tricky. And I think, we're going to have episodes that are going to focus very distinctly on, how they can advocate. It's always call your insurance company and ask your provider. That's kind of like usually the road answer. But we want to get into more detail and more practical advice for some people, because these things are complicated. And, if delays are happening and they're not getting the care that they need, and they definitely qualify for it, and they're getting hit with administrative burden, there are several layers to this that they can advocate for their loved one. Calling the insurance, letting them know, what your needs are. If you're not happy, making sure that those complaints go to the right place. And you can even talk to the providers sometimes and just say, I think mom needs this. You think they need it, and if the insurance is denying that, ask them what's happening. Like, are we appealing that? Is there something that I can do? But being proactive with that, families have a lot more power than people think. A lot of times we'll hear from families and they'll just be like, well, what? They're not going to listen to me. They'll listen to my doctor. Actually, they'll probably listen to you more than your doctor in some cases, because they don't want this trend to happen where there is, huge public outcry against insurance. Insurances are a business and want to be popular as a business, just like any other business. And And to be honest, there's lots of really great people in those insurance companies that are trying to do great work all the time. And so if you can get to the right person who can advocate for you and try to get you, in front of a medical committee or a medical director within the insurance company, and that sort of thing. But we'll get into more detail on that as we move forward, because we want to give people as much detail to advocate for their person, because and I can't get into it here because it's too big of an issue, but there's lots of ways at different levels of care to advocate for your person to make sure they're getting all the care that they need in the time frame that they need it. It's not going to work every time. It's not going to be 100%. But knowing the right things to say, the right people to talk to, that sort of thing, will really help people navigate and understand. And the other piece of this is they need to understand what is best practice. So if they know what best practice is, then they can go into a situation and go, wait a second, I don't think we're getting best practice here. And they can go to those providers and say, hey, I think, we're supposed to stay in this rehab longer than we are. Is mom getting to stay here as long as somebody who's on a different insurance gets to stay here? Those are legitimate questions that everyone should be able to ask providers. And most providers will be honest. Most providers, if they're not happy with a particular insurance or that sort of thing, they'll be very candid with those families and say, yeah, you probably should call your insurance and complain, and here's who you might reach out to, and that sort of thing. But we're going to get into that in a lot more detail, because there are several layers to this.
Awesome, John. Well, thank you so much for breaking that all down. And coming up next, we're heading in the field with Ney Ortiz. Ney is your go-to for real talk, fresh ideas, and unstoppable energy. She's all about making moves, having fun, and keeping it professional when it counts. As a rehab discharge planner and social worker, Ney helps other adults navigate the often confusing transition after rehab, whether they're going home, moving into assisted living, or seeking more support. Her work is shaped by her firsthand understanding of how challenging these moments can be for both patients and their families. And her mission is to make every difference she can, no matter how big or small. Ney, welcome to the show.
Hi. Thank you for having me.
We're so glad you're here. We're sorry. We have so many questions.
Okay. Hopefully I could answer them.
That's awesome. Okay, so tell us about your role.
So like how you said earlier, I work with James River Nursing and Rehab. I am their discharge planner / rehab social services. So what I pretty much do is when someone comes in, I kind of chit chat with them, get to know them a little bit, like their social history, their discharge planning, what they want to accomplish with therapy, either that's with occupational, physical, speech therapy, and see if we could even maintain those goals with them. And then pretty much I tell them, I'm going to be your annoying best friend. I'm going to check in on you once or twice a day or as needed. And we pretty much go from there. When it comes closer to discharge, the team, like therapy, nursing, and myself will go in, do a care plan, which is their freedom to talk to us like, hey, I don't feel comfortable maybe walking 2 or 3 steps from the stairs, and I have 3 steps I need to work on, or I notice standing for a minute and a half, I get really winded, or just any concerns they may have about going home. And we adjusted right there. And therapy or myself was like, okay, before you discharge, let's work on these things. And then home health, really. I come in and say, okay, what home health services do you want? Because I pride myself of patient's choice. I like them to talk to me saying, okay, what home healths can you recommend? I tell them I cannot recommend anybody. Here is the actual Missouri list of home healths. You let me know who you want to talk to. That's with you guys with Haven, or that's with anyone else. And I could bring someone and they could talk to you more about what their services are. Send out the referral, get ready for them to go home, and they discharge. I typically like to touch base with them like around like maybe a month just to see how they're doing. And if they're doing great, I said, great, call us if you need us anymore. So that's what
awesome.
I pretty much do.
That's awesome. So what led you to this career?
So funny enough, I was working at a behavioral hospital for 3 years. That's how I got into the whole social work case working. After I did my fill with behavioral health, I noticed James River needed a discharge planner. I just sent my application and we talked, and I guess started from there.
That's awesome. It seems like everybody kind of has a journey somewhere. Was there any personal, like with your family or anything that kind of said, hey, I think I might want to work with older folks?
Definitely what happened with my grandmother, God rest her soul, she passed away at home back in Puerto Rico. That's where my family's from, is from Puerto Rico. My grandmother was dealt with cancer, and it took her. And it baffled me. That's when I was in college, still, getting my bachelor's in psych. And it just baffled me that not a lot of people were going into the homes and helping out. And I asked my mom while she was there taking care, because my mom was a nurse, but she took that role to take care of her for her last few months. And I said, Mom, is there anyone else that could help you? And she's like, it's just me and your aunt, my sister, and that's it. And that kind of made me sad. I was like, there should be more people out there, especially for those who are like the last stages of life. So again, coming from behavioral health, I noticed James River, and I'm like, you know what? Let me test this out. Maybe this is God saying, you might want to look into this population. So
definitely. We'll dig into that gap that you mentioned, of care, because we definitely want to circle back to that. So I wanted to get into, because skilled nursing is a whole nother world, a lot of people get a little intimidated by it. Can you help describe what skilled nursing is? Yeah,
skilled nursing is pretty much one step before going, hopefully, home. If you have a broken hip, any broken bone, or you're just in the hospital for, let's say, COVID, because COVID is still rapid and still here, you will come to us. And we will just take care with you as long as insurance allows it. So that could be up to 20 days. That could be more than 20 days. And our goal, and people think skilled nursing home, they hear that nursing home and they think, oh God, I'm going to be there forever. They're not letting me go back home. I'm stuck here. And it's like, no. We're literally just here to help you get home. We want you to get better. We want you to start walking again, do your normal independent living pretty much. And then that's it. You're home. Unfortunately, some people do have to stay a little longer, and they accept that prior to coming to us. But typically, no, skilled nursing is just therapy.
That's great. And how often does therapy typically occur?
About 5 days a week.
Okay.
So you see therapy about 5 days a week. You'll see, depending on the disciplines you need, we offer all three disciplines: physical, occupational, and speech therapy. If you don't need speech, then you see physical and occupational. Twice a day, you'll see one person, and then the next person will come right after. And you're typically with them for maybe around 40 minutes, 45 minutes.
Okay.
So with them for a good hot minute.
Yeah. That's a lot of rehab. That's great.
Oh, yes.
You had mentioned that the time that they spend in the facility varies based on the insurance. Can you get into that just a little bit more? So
there is managed and
traditional Medicare.
Thank you, traditional Medicare. Mm-hmm. So as we know, if you have like Med A, you and us will have a conversation. That care plan that I mentioned earlier, we will talk to you like, okay, like you have been hitting these goals. You said you have 5 steps, but you're walking 10 steps on the stairs. You said you want to walk 50 feet. Well, you're past that. Do you feel comfortable with going home? That gives all the determination, the choices to the patient. They said, you know what? I feel ready. Okay, you're good to go home. We will set up your last cover date. You let us know what the last pieces you want to work with, and then you're on your way. And then you have
Medicare Advantage.
Yes.
Correct. Okay. Yes.
We will send in updates to your insurance, typically once or twice a week, depending on your insurance. And your insurance will decide what we have here at physical and occupational nursing site. They're doing this, and they're doing great, or they're not doing great. Insurance will unfortunately just cut you off. Like, okay, here's your last cover date. You get to discharge 2 days right after.
Okay. Mm-hmm. And are there different Medicare Advantage plans that handle that differently, or are they all kind of like
pretty much line the same?
Okay.
Yeah.
Okay. And so you're providing them with feedback on a weekly basis, documentation, that sort of thing, and who's actually making the decision on whether they're ready to go home or not?
Honestly, it's a little bit of both.
Okay.
It's going to be a little bit of both. We can only document what is true and what we see. And then you have the resident. If, let's say, insurance comes back and like, you know what, we give you 5 more days. But if I was a resident, I'm like, I want to go home. That's totally fine. we'll set everything up for you to go home. We would need to talk to your provider, whoever is the provider that they see with us, and make sure it's a safe discharge, because we want to make sure when you go home, it's safe. You have your medications, you have your home health, you have a follow-up appointment with your, preferred primary care doctor outside versus doing a AMA. Doctor says, no, like, insurance is correct. You might need a few more days with us.
And then the opposite of that, do you have ever times where you have clinicians who are like, they're not safe to go home, but the insurance is saying they do need to go home? Does that happen?
Yeah, that happens more than what people think. And it's a lot of different things. It could be for their medical, like, oh, you know what, they're not really walking as much as we want them to, or it could be a safety concern going home. When it comes to safetiness at home, if we have an inkling like, hey, this does not feel safe, we don't feel like you're going to have the proper care that your family is saying, or if you are denying home health, we will have to call the hotline.
I want to circle back to that last piece right there, because that's an important piece, but I want to stay on if a family goes into a skilled nursing facility and they're on a Medicare Advantage plan, and the clinicians are saying, I don't think they're ready to go home, but the insurance is saying, well, we're going to set a date, they're going to go home on this date. And, what are some things that family should know or can do potentially to try to help with that situation?
If the doctor, the family, and the resident all agree, and we agree as well, like, no, you should have maybe a couple more months or a few more weeks. If we have enough availability, if we have a bed, we say, hey, like, we think you could benefit with Part B, which is just continuing on with your therapy, maybe twice a week, 3 times a week, or restorative. What do you say about staying with us in long-term care? Then we have a whole, I shouldn't say issue, but a whole problematic with finances, because some people may not have that finances. Some people may not even have Medicaid, and that's going to be a whole thing they have to do to sign up. Do they have assets? Do they have the minimum under a certain amount to even qualify for that? Or do they even have the funds to do out of pocket? And if they do, who's going to take care of their home when they're not there? Or if they are still primary breadwinner, I like to call them, and they have people living with them, can they even support? So there's going to be all of those things.
Let's say, for instance, you have somebody, I'm going to go back to the appeal part of this, where you have the doctor, clinician, everybody, the family's like, they're not ready to go home. Medicare Advantage is saying they need to go home. Is there appeal process or anything they can do? What are the family, what can initiate that?
So with insurance, they will go ahead and, provide us a non-medical last cover date, right? And on the end, it says you have the right to appeal. They give them a number, like an 800 number. And I let them know, like, hey, if you still feel uncomfortable going home, go ahead and call this number. Have you and a family member talk about the needs. Take the emotion out of it, because insurance, unfortunately, they don't care about your emotions. They want to know the cold, hard facts. Can you walk this distance? If you have stairs, are you able to do this? If you live at home, are you able to shower? Are you able to cook? Are you able to do your basic living things? Those is what you need to say to when you appeal. And then it goes through a 3-day appeal. So hypothetically, let's say we get we get a NOM-NOC, which is non-medical coverage, and we get it on Wednesday, right? That is the first day you should definitely call in the appeal, because it takes Wednesday, Thursday, Friday, and typically the Friday will be your the last cover date. You discharge on Saturday. So go ahead and do in that first day. Let them know factual what you need, what you need to do to accomplish your goals. And then by that Friday, we should hear, you know what? You're right. They should have at least maybe 5 more days, 3 more days. Let's review it sometime next week. Or there has been some cases they're like, nope, you're still going to go home.
Okay. So when I'm just want to make sure that the families that are listening to this really fully understand who is actually initiating that appeal. Are they actually physically calling at your, I guess, guidance, or is the facility calling?
No, it will be the resident and their families.
Okay.
I will give them it will be like a piece of paper. I said, okay, if you want to appeal, I will give you a copy. I need the original so I could send it off to your insurance. I will highlight absolutely everything. Like, call this number like today. The moment I leave this room, call them. And luckily, on that piece of paper, it has the insurance number on it, because they're going to ask, okay, the insurance number, we need that. Who are we talking about? Exactly what they've been doing in therapy. And then they're going to ask $1 million question. Why do you think we need more days?
Right.
So it'll be just family driven. I cannot talk to them because it's going to look biased. It's going to look like I'm favoring them, which is not true. Like, I want to make sure everybody has their needs met.
Right.
So it'll be family or the resident.
Okay. Now, going back to the financial side of it, so the skilled stays covered. I tried to appeal, that didn't work, and now we're to the part where we're saying they're not ready to quite go home. Our appeal failed, so now we're going to offer for them to go on what's called Medicare Part B, which can you help explain what's covered under Medicare Part B and what's not covered?
Before we go into that, we need to go into, are they willing to stay in our long-term care if we have the beds available, or if another nursing home have beds available? So we got to go with that first. If they say, if it was like, let's say it's my own father, right? And we both agree, you guys agree, like, yes, he needs to stay. Okay, do you have a bed availability? Sure, yes, great. How much does it cost? Does my father have Medicaid? If my father does have Medicaid, great. But we had to understand all of his income, at least for James River, all of his income minus $50 will go to the facility. All right, perfect. We're done there. So now Part B services. We had to send an authorization to the insurance saying, hey, we want to see them for Part B. What do you guys cover? We're wanting to see them for physical and occupational. Here's our evaluations. What do you guys say about this? If they said, you know what, let's go ahead and do Part B twice a week for 4 weeks. Perfect, right then and there. And then after 4 weeks, we'll talk. Well, at that point, it'll be long-term care. They'll talk, okay, are they ready to go home? Are we okay? It could be a yes. Or do we need to start restorative, which is just basic walking, and then restart Part B and then go home? But we always have to ask first, like, hey, we understand you're uncomfortable with going home because you're wanting to do all these things, but how do you feel about staying here or another long-term care?
So just to make sure I got it clear, the Medicare Part B is going to cover the kind of the medical portion of their rehab.
Yes.
But then the rest is going to be their stay there is actually going to be privately paid, either through Medicaid or through their own private funds.
Yes.
And you'd said that sometimes when they're in the middle of these situations, that is there assistance with applying for Medicare, because some people may come through the doors. It looks like they've had, let me just give an example. They've had a severe stroke. It looks like they're going to be long-term getting rehab for a long period of time. The insurance may, Medicare Advantage may or may not cover that full amount of rehab that they need. They need to pay privately. They are married with a spouse at home with a nest egg. And, I don't know what the cost of James River is per month, but, I would say in the ballpark of a lot of skilled nursing facilities, somewhere between $8,000 and $10,000 a month, somewhere in that ballpark. And so how do families navigate all of that?
It's a very long process. If they go into rehab and family and the resident all understand, like, hey, like, we're actually just not going home. We're going to be needing to stay. That's when they'll speak with our business manager, Megan. And if, let's say, they don't have Medicaid, we could start applying for Medicaid. There'll be Medicaid pending. If there is a spouse, I always heard the term elder law. You might want to utilize them, because we're not going to have one person not living in the home because everything needs to come to the nursing home. No, they had to have their means as well. But Medicaid pending is something we also take as well.
What I'm trying to do is help our listeners understand the financial impact of some of these more serious things that are unexpected, that end up being a way bigger financial cost than they were initially anticipating, and what what are the steps that some of them have to do? Because I do know that people go into retirement with a fixed income. They have this nest egg that they're expecting to use for, decades, sometimes after they retire. And then all of a sudden, now we're going to pull from that nest egg a significant amount, which can have a drastic impact on their personal life, of course. And we're just trying to make sure that they understand what those things are so that they can start to prepare for some of it.
From just experience, we had somebody who had what you call like a pretty nice nest egg, right? Nest egg. They just pay privately at that point. If they're like, you know what, I could pay a whole year's worth and I feel comfortable with doing so, we don't stop them, because with Medicaid, you have to be under a certain threshold to even apply and even to be even looked at. Yeah. So if you have, let's say, $100K, you're just going to be paying privately for a while until I think you had to go under like $5,000.
Have you run into a situation where, it was, I guess, off of that subject, it could be anything, but if you run into situations that came out to you that seem like there's a gap in service, you had mentioned that before about your grandmother, and just concerns that they're going to go home, they're not going to have the care, they don't have the finances and that sort of thing. How often do you see things like that?
Weirdly enough, I probably see it a couple of times a month.
Oh, okay.
But when it does come around, I give them the best information I could give them.
Sure.
And when family come and they get really nervous, like, my mom isn't 100% better. Like, you said you would fix my mom. You said she could walk. You said they could do this. And it's like, we will never promise you that. We will promise we will do the best we can as long as they're doing their best. Perfect thing. I get a lot of people with broken femurs. A lot. They fall, broken femur. They fall again, broken femur. We will just help them regain their strengths with that. We will help them stand for as long as they're able to stand, or help them utilize walkers, canes, wheelchairs for them to be mobile again. And as long as they feel safe using those tools, they're good to go home. And again, and it's cautious. I'm like the same way with my own parents. It's like, are you sure my dad's okay? Are you sure my mom's okay? Are you sure if I leave them home alone for an hour, they're not going to fall out that nice comfy chair? No, they will be fine. So a lot of people, they think we will fix them 100%, which is no one's going to go back to 100%.
We are in a rural area. And I know that access to care can be a little tricky. I'm assuming it's different if they live in Springfield versus out in a rural area. What challenges do you have related to that?
I also lived, before moving to Springfield, I lived in a rural area where like it was hard to get anything. Once they tell me they are living in like the Amish town, I always like to call it, or the country town, I immediately from day one start looking around. I start calling people. I start calling the home health that I already have contact. So like I'll be calling Alex, like, hey, do you guys service, Ozark or Seymour, Marshfield, and go from there, calling all contacts before discharge plan actually starts, because I want to make sure when it comes to their care plan, which we will talk about discharge and therapy or just one-on-one conversation, I have all the data I need. Like, okay, here are some home healths. Here is some like in-person, like if you just need someone to be with you, these are the contacts. Or if they already know somebody or they have an idea like, oh, we want to try this company, I'm going to call them like, hey, I have somebody who lives in this area. Like what services can you guys provide? So it's a lot of calling on my end.
Are there some unused services or supports you often recommend?
Actually, the main one is like going back to like the whole cooking and cleaning. I put both of them together apparently. Or even just having someone, if they already have a home health in mind or they're already established and I could already tell, and I tell them, okay, you're going to need somebody with you. Depending on their home health, I'll be like, use those services. Use them. Let me call them and let them know you're thinking about them, or you call them. I will give them like a business card. Like, you call this person, tell them about the services you're going to need. Or if that, unfortunately, like sometimes it happens, they just don't, like that home health may not have enough staff, I'll just use another that's strictly just for transportation, being with them. Like, use them, please. Call them. Unfortunately, there'll be times you can't, involve your family, you can't involve your friends, but you can definitely use these services. So
that's great. That's great.
Some fun facts about you, surprising fact, written down here. Okay, let me read this correctly. You almost lost your left arm to an alligator while fishing as a kid.
Yes.
Tell us about that story. That's insane.
Yeah. So we lived in Florida. I was born and raised in Florida. And my dad, he used to take my sister, my sister and I, and sometimes my cousin fishing every Saturday. That was a ritual. So this particular Saturday, I was 6 years old. And we're finishing. We're in the Keys. Big thing about Florida, do not go in the water. Whatever you do not go in the water because there's always going to be either a garfish or a gator. Don't go in there. I was 6. I didn't care. Man. So I'm fishing and I notice my line is stuck on what I thought was a log. So what do? I hop in the water, I've reached my hand out, and next thing I know, I hear it hissing. My dad picks me up and bolts to his truck, and I hear, "Run, get in the truck." And I see my uncle. My uncle was with us. I see my uncle, he grabbed my sister, he grabbed his son, my cousin, and we bolted to my dad's truck. And I had like a little, teeny tiny little scratch over here, and I turn around, I see like 3 like adult gators running after us.
Oh my gosh.
Yeah. And like
that must
my
have been
dad,
terrifying.
He like yelled at me. He's like, "You never put your hand in the water. Why were you in the water?" And I was like, "My line was caught." Yeah, it wasn't until years later I realized my hand was actually like in the gator's mouth.
Oh,
so
my God.
My dad called my mom. She's like, "You got to go to Broward Hospital. I got to get some shots in there because like his teeth did a whole slink." And yeah, it wasn't deep enough for me to get stitches or anything, but just enough for me to get shots as a kid. And I'm like, I didn't do anything.
And
I was just fishing.
Lesson.
A lifelong lesson. So kids, if you live in Florida, don't go in the water.
Good advice. People will get all kinds of advice they didn't expect on this. On this podcast for sure. So advocacy.
Yeah.
It's your passion.
It is.
Tell us about it.
If you have a family member in a skilled nursing home or whatever, it is your job to advocate to the doctors, advocate to the social workers. Be the voice that your loved one can't have. Because what I notice a lot, especially with the generation we're working with, they're so afraid to ask for help. They're so used to like, no, pain is not real. No, I could do this. Like, you're not going to stop me. But they are like, wait a minute, never mind. I'm not going to say that. I'm not going to ask for help. That's when you jump in, or that's when I jump in. Like, no, you do definitely need this help. If you need to speak to the doctor, I'm going to make sure the doctor comes in right then and there. If you need, to talk about therapy services and they just haven't make it in, I'm going to come in, I'm going to grab therapy by their hand, like, hey, they need to talk to you about this. Or if you just, as a loved one, again, like just thinking back about my grandmother, and I wish I knew what I know now back then, to call around and be like, hey, my grandmother is sick. Like, you said you're going to take care of her, but I am not seeing this. We're going to have to change this. Either you do something about it or I will do something about it. Just advocate. You are their voice.
Be the squeaky wheel.
Literally be the squeaky wheel. I love when, I call them kids because, I get their parents. Mm-hmm. I love when their kids call me like 4 or 5 times a day asking, hey, is my mom getting this medication? Hey, is my mom is getting up to do therapy? Hey, has my mom gotten her morning shower that, she wanted and not an evening shower? Or, hey, did my mom get bacon? She wants bacon.
Right.
And be like, you know what? Let me touch base with that. Let me get that for you. Or just anything. Call. Talk to us, advocate, because if you do that, then I'm able to do that for you as their rehab social services. So, yeah.
Yeah, I think a lot of families sometimes don't know where that line is and feel like, well, I've got to let the professionals do their job. But at the same time, and that's what the great thing about this, getting this message out there to as many people as possible is that there's there's a wide variety of how care is provided depending on the place, and they need to have an understanding of what to expect so that they can advocate and go, I think mom needs to stay here longer. I think she needs more rehab, or I think, that sort of thing. And I know that's sometimes hard to do as a family member, but as you said so eloquently, it's so needed.
Just ask questions. Like I tell people, resident and their family members, like, hey, like here's my business card. I'm here Monday through Friday from 8 to 5 o'clock. I'm normally in this hallway about maybe twice, 3 times a day, just popping in, making sure you're okay. If you have questions and I already say I've seen you 3 times already, and by the 3rd time, oh, I forgot to ask, call light, use your call light. The aide or the nurse will come in. Hey, I need to speak with Ney. Or because my business card, I will give it to the families because, you guys have to work. It's okay to be working, doing your lives while your parents are gaining care. Call me. Call me during your lunchtime. Call me anytime from 8 to 5. We do have now a new phone system, so even past 5, leave me that voicemail. I will call you back the next day, and we could talk about any questions you may have, anything for you to make sure your family gets home safe. So.
Well said. One of the things we wanted to touch on was the purpose of care hotlines.
Yes. So there's always a stigma, especially in movies. Someone from APS, Adult Protective Services, will come in and it's like this tall person with a suit, mean face, with a clipboard, trying to say, "Ha, we got you." That's not it. That is strictly not it. As mandated reporters as we are, if we hear something, see something that includes abuse, which that could be physical, sexual, verbal, misappropriation of funds, even isolation, fun fact, is considered abuse as well. We will have to report that. In some cases as well, I have reported about how the house is. There is one that they said, oh, we stack things from floor to ceiling. And to me, that's a hoarder. And we got to report that because what if something falls over, boom, resident gets hurt, they're back in the hospital. Or what if the home is just messy? So I will call in, again, the Adult Protective Services, and I let them know my concerns, saying, hey, ABC 1, 2, 3, here you go. These are my concerns. And they will just check in. It's like, okay, we're checking. And they will always call us back saying, hey, we just want to let you know we checked in ABC. And yes, we're going to be doing something about it. Or thank you for your concern. Do you have any more, things you want to talk about with us? And they will just go from there. Mm-hmm.
Oh, that's great information. So do you have any advice for caregivers under stress?
Listen, it's okay to be stressed. It's okay to feel overwhelmed, and it's okay to feel like you can't do this anymore. Whenever you feel that way, you got to utilize, it's called respite care. Ask around any nursing homes like, hey, I just, do you have a bed available for maybe a week or two? It's for my parent. I'm their sole caretaker. We both will need a break from each other. Or, we just feel like mom and dad might just need to utilize your services for a little bit. Or if you can't do that, which is okay, ask another family member, ask a friend that's willing to see your parent or your sister or your loved one for maybe a day or two and just take that break. Because I always like to tell people, how do you expect to take care of somebody if your mental health, your emotional, and your physical is getting a toll on you? You're not going to give them adequate care that they deserve. You're not. If you're stressed, overwhelmed, you got to take at least a day, at least a little bit, and just refresh. But do it safely, please.
Great advice. Great advice. So I'm just curious, in the last, let's say, 6 months to a year, how full has your facility been? Has it been full a lot, or is there usually a bed available most of the time?
It's really day by day. Right now we are under construction, remodeling, where hopefully we'll be done in the next few months. But when I first started, before the remodel even started, rehab, it's always a turner. We have, I believe, 22 beds. each day is different. I may be full with 22 and then the next day I have 15, or vice versa, whatever. With long-term care, it's literally a day by day. We may have a bed, 3 beds available, but depending, do you need male or do you need female? But at least for rehab, it's quick, it's turn. We normally will have a bed available.
Where do you see the industry going in the next 5 to 10 years, especially here in Missouri and the greater Ozarks?
Just communication throughout the board and just understanding that we're all trying to do our best, that we're all a huge team. Like, I can't do my job without you guys, and you guys can't do your job without me, or, rehab. Maybe just more services, like being able to cover more ground, more smaller cities, because going back to the whole rural thing, it's hard. It is hard to cover them. And I guess it's just mainly just communication, just helping each other out. Yeah.
That's great. So are there any initiatives or improvements to James River that you're really proud of?
I love the moment when someone comes in, you will be greeted by pretty much management right then and there. And then you're greeted with the charge nurse, and then you're greeted with your aides, because what we strive in is just compassion, top notch. That's our mission. We want to make sure you feel as comfortable, and we want you to feel at home away from home, because it's scary going from home to hospital and then to James River or to any nursing, skilled care. That's our initiative. That's what I love. I come in there, I sit down, I'm like, okay, my name is Ney. Let's talk. What's going on? What brought you in here? And I like to let them go a little bit loose. We'd be sitting there chit-chatting for like 30, 40 minutes about everything under the moon and stars.
Yeah, that's great. Just getting to know them really well.
No, just getting to know them, because they need a friendly face. They need someone that they can remember, I'm having, a little bit of concerns or a little bit of questions. How am I going to get home? Let me talk to Ney. Ney was there when I first got there. She introduced her. She sat right in front of me, and we were talking about my grandkids. She took the time to actually listen and repeated back my kids' names, my grandkids' names. She knows where I'm from, and we have these in common and things that we just talked about.
That's awesome.
Oh, yeah.
Well, you can tell your passion really comes through for helping people who need it.
I'm definitely a people person, and I am a certified yapper. So I can sit down and talk and talk and talk. Certified, and I'm like, I forgot to ask you these questions. I know the nurses out there. Give us another 10 minutes. Anyways, work time.
That's awesome. That's awesome. So just kind of a final takeaway for families out there that, they're stressed about skilled nursing, or nursing home in general, what are maybe some of the major myths that you think that people have, misconceptions they come into the door with that they should understand that aren't true?
We're not like how the movies portray us. Like, we're not the little scary, like, nightmare. No. You'll always see a smile on our faces. You're always going to hear us say, anything else I could get you? Or, hey, do you want some more water? Or, hey, you want to go outside? Let's chit chat. We see you're feeling sad. Like, what's going on? Talk to us. Like, and also, whenever people come from, like, again, going back earlier, I said people are coming from rehab, their first immediate thought is, I'm never coming home. No. If you are determined to go home or to be discharged to somewhere else to be closer to family, or just want to go to another place, we will try to make that for you. We will try to do everything in our power to make you feel comfortable, and also to make you feel like you have a say, because you do have a say. You have a say in your care. You have a say where you live and how to be taken care of. So we're not like the movies, I swear.
Yeah. Well, thank you so much for being with us. You've taught us so much about skilled nursing, what things to look for and look out for, and if the processes don't go to plan, here's what are possibilities. So thank you for that.
Yeah, thank you.
What about Ney?
Wow.
What do you think?
She was fantastic. So much good information for everybody.
I love it. I loved how she focused in on making sure that families advocate. They need to do that more. They need to go in these situations and be the squeaky wheel. A lot of people are like, well, I don't want to, make someone upset or make someone angry with me. But to be honest, the squeaky wheel does get the better care. Unfortunately, that's just kind of how things go. And so if a family member comes in and they're very demanding about things, a lot of times those facilities really step up and they are more careful and provide a little more attention. And so, all the advocacy you can do for your loved one really makes a difference.
Absolutely. If you enjoyed today's conversation, make sure to like and subscribe so you never miss an episode.
And we'd love to stay connected. Follow us on YouTube, Facebook, and on Instagram at In Good Company Eldercare Podcast.
You can also find us on X, formerly known as Twitter, at IGC Pod, and on TikTok at IGC Eldercare Podcast.
Thanks for tuning in to In Good Company Eldercare in Your Backyard. I'm John Ray, and I've been joined by my amazing co-host, Spencer Ernst. Special thanks to our executive producer, Alex Wallace, for helping bring this show to life. Until next time, take care, and remember, you are always in good company.